I'm pausing just for a minute because every time that I don't, it cuts off my introduction, and I think my introduction is just phenomenal, at least in my own mind. All right, everybody, welcome to Coffee, Compliance, and Chuckleheads, episode 16. I don't have enough fingers to do 16, but XVI, and we are calling this one Fraud of Dreams. I did a little bit of I don't know, whatever you would call it, cut and paste onto a Field of Dreams picture, and given the fact that I really kind of stink at doing that, I got a few comments from folks that were like, wow, really like the marketing piece there, Sean. And I know I could always depend on Jill to just make me feel so good about everything that it is that I do in life. So, but anyways, I want to.
It shows what our budget is.
That's right. We set the bar high.
Our budget is coffee, and I actually have coffee today. I'm drinking a little Cafe Bustelo. I don't know if anybody drinks that stuff anymore, but I drink it because it's cheap. It's like $5 for 46 pods at Walmart or something like that. But anyways, I want to say, even though it's the 19th of January, 2022, I want to say Happy New Year to each and every single one of you that is tuning in, logging on, and just hanging out with my really good friends, Jordan Johnson and Eric Rubenstein. We're so happy to see each and every single one of you. If you're not joining us live, but you're watching the recorded version or you're catching us on the podcast, again, thank you for hanging out with us for just a little while. We have an extremely packed agenda for today. But, you know, it wouldn't be an after hours show if we didn't kind of, you know, talk about some after hours things. But, you know what I started watching again? Game of Thrones. Have you guys watched that?
I feel like it's a good metaphor for life right now.
It is. It is definitely.
No, it's on my list.
I'm telling you.
I got to get to it.
It's fantastic. You got to watch it. I mean, obviously, I'm a Yellowstone guy, and I was very disappointed with the last episode of season 4. Just did not hit. Didn't hit. I was really hoping for so much more.
You know, very, very, hopefully that's not like our listeners think about us, you know, and the bar was set high and it fell way short.
Yeah. Well, with that said, let's go ahead and get right into this thing. We have a lot to talk about, a lot going on, and I want to make sure that we cover everything that needs to be covered here. So with that said, let's go ahead, Eric, and talk about one of the first things that I know was on your mind, and that's the COVID home testing kits.
Yeah. So if people are keeping up, they're seeing that the other day, the website for home test kits went live. The government sponsored program for ordering home test kits. So of course I go up on the website because I got to check it out and get my free kits. And immediately my antenna go up because I find that the website is actually being administered and the mailing of the kits is being administered by the U.S. Postal Service. And so that gave me a little bit of a pause. You know, as a longtime government employee, I understand the trials and tribulations of things in the government, but the Postal Service, I mean, we see all the time people getting arrested for throwing the mail away, postal carriers. We see that if you mail something, unlike FedEx, where they say it absolutely positively has to be there overnight, it's, hey, we'll get there when we get there. So, you know, the first concern is, you know, if you've been on the website, the way that it works is you put in your name and your address and an email for confirmation, and you order 4 kits, and it's 4 kits per person, named person at the address. So if there's multiple people living in your house, you theoretically can order more than the 4 kits to that address. But, you know, obviously the problem now is going to be that these kits are going to come in and people aren't going to need them. And there's going to become now a gray market because there's people that need them. You know, I have friends who were showing symptoms and just absolutely needed to be tested. I have friends that work in the healthcare industry. They needed to know, is this a cold? Is this COVID? What's the story? Friends of mine who have kids who've come down with symptoms. Is it a cold? Is it COVID? You know, what you choose to do based upon the response of that test is going to be something that you're going to choose to do, right? You should be staying home. You should be, but, you know, people need these tests. There'll be a level of desperation for these tests. I'm going to give it, once these tests get delivered, I'm going to give it a week. They're going to be on eBay. They're going to be on your black sites for purchase. They're going to go to the highest bidder. You're going to see it. You're seeing it now. It's going to be more prevalent than it's ever been because now we're introducing them more in the economy. And the thing that I've equated this to, and I talked to Sean about this a little bit, and actually Sean and I are going to be doing a presentation in February, and I'm going to talk about this a little bit more. But you know, in the diabetic testing world, with strips and needles and all of that, there is a very well-known fraud scheme that's known as carouseling. And that is, you know, as a Medicare beneficiary, you're entitled to receive a sum of diabetic testing supplies. Typically, they're produced to you through the competitive bidding process. You get them. And then what happens is you get them, you're supposed to test 3 times a day. You test 2 times a day. Sometimes you forget. One thing leads to another. Every 90 days, you're getting another shipment. Before you know it, you've got a half a closet full. And due to the unscrupulous telefraud schemes, people are getting you to switch suppliers because it's very easy. And the program has a fairly large weakness, which is that the onus is on the beneficiary to cancel their account with one supplier for another. Well, how often does that happen? I mean, it just doesn't happen. I was showing Sean today some photographs of some things where there's just, you know, warehouse level amounts of these diabetic test strips. And I worked on a case a number of years ago where it was literally in a basement, just thousands of boxes of strips that had been bought online where they were cleaning up the boxes. They then go and sell those test strip boxes or the Lancets or whatever the supplies are, the control solution. They then go and sell those through eBay or something else to another retailer, a pharmacy or something like that. So that product that's already been purchased once by the program, whatever that program is, a lot of it's Medicare, could be commercial, is now been sold for pennies on the dollar by someone like me who didn't need them. So I'm making money because it didn't cost me anything, right? And now they've been bought for pennies on the dollar by some, you know, third-party retailer. You can see it. You drive around, you see these signs on in the lawns. You see them on lampposts. Diabetic, you know, selling diabetic testing supplies.
Absolutely.
We buy diabetic testing supplies. There's no way to track them back to the original. You can track them back with a lot number to the original point of delivery. So when Abbott has their Freestyle Light strips and those strips are sold to Walgreens, they'll tell you they were sold to Walgreens, but they can't get you to the granularity of necessarily the store. And then once they've left the store, then there's no tracking of them whatsoever. You know, if there's an expired, if there's a recall, those are just out in the wind. And then they're purchased 2 or 3 or 4 times. And it's called carouseling. And, you know, essentially, you could take Medicare, which is a pretty big purchaser of these items. Medicare is potentially buying the same exact box, right, 2, 3, 4, 5 times. And there's no way to identify how that's happened. I've worked many of these cases. And, you know, I would go back and I would say these boxes have to have not just a lot number, but they also should have a serial number on them. And when a claim is submitted to Part B for them, there should be a place on the claim form, free form, wherever it could be, even if it's in an unused CPT line, to be able to put in that serial number. I mean, it just needs to be there for tracking so that you know that you've got this sort of recycled situation. This is exactly what is going to happen with these test kits. The difference is going to be that the people that need these kits, which would otherwise be free through the government's program, through desperation, people are going to pay for them. The first issue is that they're free now. You're getting 4. At what point is that stopped? The government is not going to incessantly continue to purchase these. I read an article that said that the estimated cost for these is going to be $4 billion because they're talking about 500 million kits or whatever it is, $4 billion. So now reality is I got 4 test kits. I'm fine. I'm fully vaccinated. I've also had COVID. And now they're talking about that the best protection are people who are both vaccinated and have COVID. So, I get a test kit, maybe I'm not going to even have symptoms. Maybe I'm not going to need it. And I'm going to be, I'm going to be good to go. And so we're going to a situation where we've got test kits going out on the market that were otherwise free, in which now we've got a level of desperation. Tack onto this, and I'm sorry I'm rambling, but tack onto this that there was an article out today that says
you don't ramble.
I do. The government is now going to make 3 N95 masks available at either a CVS or a Walgreens. So I go to my local CVS or Walgreens and I pick up 3. How is that going to be tracked that I've gone to a CVS or a Walgreens and I don't now have a situation where I'm hoarding N95s like we had before, and those N95s aren't ending up on some eBay website or something like that?
And when you get the knockoff, if somebody gets sick, because odds are when I go get mine, I'm going to get an N59 instead of an N95. I mean, I'm going to get the knockoff. They won't give me the real one. But you said $4 billion to pay for the test. That doesn't include these masks.
That's right.
So then you tack on the mask. I mean, it's just like a catalyst of fraud opportunity and at the taxpayer's expense.
Right.
Absolutely, it is.
Yeah, and our friend Robert Lyles put in, the buyers and sellers can further complicate the fraud by changing or removing the lot number. The fact of the matter is, at the end of the day, the buyers and sellers don't really care, right? The buyers of these products are buying these through their third party. Now, I will tell you what the manufacturers have done is the manufacturers have created a system where you have to be an authorized and there's what they call a pedigree system. And so what that is doing is, it gets a little complicated with diabetic testing supplies, because if you go to a pharmacy to buy them, you're actually using your Part D prescription benefit, which then rolls back onto a Part B. There's like a matching. It gets very, very complicated because most pharmacies aren't Part B participants. And so what'll happen is, in an audit, a pharmacy that gets audited for their diabetic testing supplies by the PBM, the pharmacy is going to have to provide their invoices for the information that they produced. And as part of producing that, they're going to have to show not only the invoices, but they're going to have to show the proof from the manufacturer, from their wholesaler, that they're a pedigreed wholesaler. Robert's talking about how the misbranding can be prosecuted criminally. I will tell you, the case that I had was a very large diabetic testing fraud case, huge case. There was misbranding that went on. It was not prosecuted criminally. It was a civil case. It had to do with putting labels over the boxes. They were made outside of the U.S. They weren't for U.S. use. There was a sticker put across with the name of the company that supplied them. It wound up being a civil case. The same owner of that company, who was not excluded, him and his brother wound up engaging in a further fraud that led to $12 million in fraud for almost the same thing. So, we have found these, along the way. But the point I'm making is that at the end of the day, we're putting a bunch of stuff in commerce for free that actually has an economic value to it, and a bit of a panic value to it. And so the free piece is going to eventually be a cost factor.
But on a good note, the administration just said about 10 minutes ago that inflation is a problem. so I mean, we're just pumping it into here, guys. I mean,
absolutely.
Now, you mean the inflation that's at the highest level in 40 years, not 30 years, 40 years. Okay.
Yeah.
Okay. But, to your point, Eric, right?
Yeah.
It's not that we're putting something into commerce that is free. You made a very valid point, right? Because it does have an economic impact, right? And the fact that people were like, "Oh, I get my free testing kit." Well, guess what? It's not a free testing kit. That testing kit was paid by who? The taxpayer dollars.
Right. So what I've got on the screen, sort of to bring that in, let's see if I can get this a little bit bigger. But what I did was I went online and I took a look at some of the forms that are now available. So if you are covered by insurance, so here's where this other issue is that the Medicare population, which is number one, they've already identified that the elderly, the Medicare population, is at the greatest risk for health-related issues from COVID, right? So the group that should be testing the most, have the masks the most, and have the greatest ability to get the immediate results of a test or something along those lines are excluded from being able to go purchase a kit and then seek reimbursement from the Medicare program. So this is only for the commercially insured. And so what this form is,
our government at its finest.
Yeah. So what this form is, this happens to be from one of the BUCAs. This happens to be from Cigna. I just happened to find it, so it's not this isn't any sort of thing with Cigna or anything. I've looked at other forms since I pulled this one down. They're all actually very similar. They're all pretty standard, but the thing that's going to be the kicker is going to be right here. When submitting your OTC test kit claim, please include the required documentation with your form. Incomplete submissions may not be considered. Purchase receipt clearly showing the date of purchase and testing kit charges. And so, the problem is going to be, here we go. I'm in right now an Adobe PDF editor. And, it'll take me about 2 seconds to make an alteration to this document. Now, that being the case, at the end of the day, I get my receipt. It's not going to take very much, right? You get 8 kits per month. They're supposed to be reimbursed. And by the way, the caveat to that, if you have a doctor's order and you need additional kits over the 8, your insurance would have to cover those additional kits that you would purchase. So let's say I stick with the 8, but I buy my initial 8 and now I don't buy any more. I put in my reimbursement form with my receipt. Guess what? I now have a scanned copy of my receipt. What stops me from making a couple of very simple changes?
That's right.
Date of purchase, the time of purchase. So all you need to do is change the time and the date stamp, which is unbelievable to me that there isn't some other way to, and I don't know necessarily what the answer is. I know that one of the things that I had heard was that people were suggesting that this be treated like a prescription point of sale, right? The problem is that because this wouldn't be a pharmaceutical benefit, what I just talked about with diabetic test strips is not really going to be dissimilar. Pharmacies can't process these claims. There's no CPT. There's no HCPCS for it, right? There's really no diagnosis.
No, they're going to have to use a 999.
The 99999, and the diagnosis is going to be some community exposure, the Z code, or something.
But this
like
brings
that.
up a really interesting point, right? So take a look at this question. And the question is, back to the COVID test. Assuming that an individual tests positive, is the government going to pay for the PCR testing? Well, here's the problem. If the patient showed up simply saying, I'm asymptomatic and I'd like a PCR test, where's the medical necessity? Now, they just so happened to test positive and they didn't realize that they were exposed to somebody, if you're not getting, how long is it taking the PCRs where you guys are to come back? Because it's taking like 24 hours here.
Yeah. So I will tell you, I have 2 COVID lab projects that I work on with Advise. One of them had an inordinately long delay. They had their staff working 24 hours a day, 7 days a week. They were paying bonuses to the staff to stay. The problem is that during the Christmas holiday, there was an inundation. Quest and LabCorp, not who I'm working for, Quest and LabCorp, and I know for sure Quest, but I heard LabCorp. Quest on their website actually was posting that they had a delay that was running a minimum of something like 48 or 72 hours.
Right.
That's dropped substantially. But if you think about it, you get a PCR test and you test positive, but as a result of the delay, you don't get your results for 4, 5, or 6 days. If during that delay you're not tested, let's say they don't get you for 6 days,
Mhm.
Isn't there an argument of medical necessity to even run that test to begin with?
Right now, Quest is saying on January 6th that their average time due to capacity is what you said was 1 to 3 days. But if you Google it, because Google knows everything, apparently, CBS News says that due to increased demand, an average turnaround time for the PCR is 3 to 5 days, but with the caveat that they're now putting that it could take longer, which brings to your point, Eric, is once you exceed that 5 to 6 day threshold.
Why do you always tee me up?
Me or Jordan? Me or Jordan?
Both.
Just say yes. Just say yes.
I mean, okay. So, did you all see the interview? So keep in mind, I am a moderate independent. I'm not a Republican. I'm not a Democrat, right? I am a moderate independent. But did you happen to see the interview last week with our vice president where she said, just Google it? Every question that she got asked, she said, well, just Google it. It's like, when you want, quote unquote, when you want to make a reservation for a really good restaurant across town, don't you just Google it?
That's right.
Oh, yeah. Well, let me Google how to do, a hemispherectomy or something like that. I mean, come on, man. Anyways, but here's the deal. Where I was going with this, and I think where Robert Lyles was going with that question, right? Because what he said is this. Assuming that an individual tests positive, is the government going to pay for the PCR test? Well, here's the question.
Right.
Are you submitting your claims every single day? Or are you waiting for the lab test to come back so that you have a definitive positive or negative? Now, if you are, then potentially, yes, you're submitting it with a positive diagnosis and the carrier is going to have to pay. Why? Because it doesn't matter whether you were asymptomatic or not. You tested positive for COVID.
Right. Well, the issue is that unless you're going to test every single morning before you leave your house, then testing, having 4 test kits, by the time, all of the 3 of us have all had COVID, right? So we know, and many of the people that are listen and watch have had COVID. The fact that I just saw something the other day that says right now 20% of the country has had COVID, and it's growing. Right? Everybody's going to get at least the Omicron. So the issue really is that if I'm only testing twice a week or whatever it is, it's sort of like what if I test on a Monday and I'm negative and I'm asymptomatic, but I get it on Tuesday, and I test on Friday and I'm like, ooh, I've had COVID for 3 days. That the ship is sort of sailed at that point, right? But right. I mean, my concern is that with anytime you've introduced something in which there is, it's a guns and butter, right? It's your basic economic premise. What does the government need? What does the people want? Right. The people want masks and they want testing. And it's really, what is the economy? What is the market willing to bear? Right. I mean, we see this with housing costs growing. We see this with gas. We see this with everything. And many of the things that the government has no control over, like the contrary to what everybody thinks, the government has very little control. The presidency has very little control over the price of a gallon of gasoline, right? I'm not saying 100%, but
wait a minute now.
To an extent. What I'm saying, and I want to get in this discussion, but the point I'm making is that when we start to introduce things into the economy that the government can control for everything, and this gets back to sort of the premise of CMS, that CMS always wants to try to do something that is the right thing. And that oftentimes in doing the right thing, it opens up the door to inordinate amounts of fraud, waste, and abuse. Do I think giving the masks out is a good idea? Of course. Do I think that giving test kits out is a good idea? Of course. There's a need for it. There's a run on these things. The reality is, though, is at the end of the day, and I don't know how you stop this, but after I get my kits, I will then immediately be going online looking to see where I can find the exact same kits or similar kits for purchase, because it's going to happen. You're going to see them at flea markets. You're going to see them at your less desirable establishments for
Dollar General.
Whatever. Yeah, you're going to see them. You're going to see them in the corner bodega.
But people think when they hear me say Dollar General, people think I'm joking. This is directly tied back to carouseling, what you were talking about, where the people are going to be putting these things for sale. They're going to be swooped up by all these wholesalers who are then going to turn them around and sell them to these discount retailers like the Dollar Generals, the Dollar Trees,
Right.
all of these. That's
Right.
where I'm not making a flippant statement. I'm
No.
being
That's where, I mean, you're going to see these things in bodegas.
yes.
I mean, it's just, this is where this stuff is going this is where it's
Well,
going
Matt,
to
your
happen.
point, where do you draw the line and when do you stop it? Because now the people are going to become accustomed. So we get our first 4, but then, like you said, well, that lets us test for 2-3 weeks, maybe 4 weeks at the max. If you do 1 a week and you try to conserve your test, what happens after that? Then is the people make enough noise that we get another round of 4, or do we get another?
Yeah.
And so that's where I'm going with
But
this. Is to your point, where do you stop?
Yeah. But here's a good point from Jill, right? And this is such an incredibly important point, right? Because this point ties back into what Jordan was just saying just now. When a patient gets a positive test, they want to call their primary care doctor to prescribe meds. Very unfair to the doctor. I agree, because you can't pick up the phone and call your doctor and say, I need you to prescribe a medication for me.
Why?
Well,
because
now
I
you're getting-
self-tested.
Right. I self-tested and who knows? Remember, to get an accurate test, you got to take that thing and basically scratch your brain with it and leave it sitting up there for about 5 to 10 seconds.
Right.
But here's the point. Now this could potentially, and I know Robert's on here, and I know we have about 60 people listening between LinkedIn and all the different platforms. So I'm really excited about that. But here's the thing. If there's any attorneys that want to opine on this or chime in, think about this. Now you're potentially running into a med mal issue, because if I pick up the phone and I call my doctor and I say, I tested positive for COVID, right? Now, we don't know. There's 22 variants or 23 variants or whatever it is, but the dominant one right now is Omicron. But nobody has said that Delta is still not out there as a variant. Omicron just happens to be becoming
right.
the
95% of cases are Omicron.
That's right. And 95% of the cases of Omicron are in vaccinated people. So remember, the vaccine, this is so important. The vaccine doesn't prevent you from getting the virus. It cuts down on the potential of death and or of the need for hospitalization, which I think is tremendous. And somebody who has underlying systemic, heart disease, atherosclerosis, whatever the heck you want to call it, for me, that's enough to make me say the vaccine is worth getting, right? Because I don't want to wind up in the hospital. I don't want to wind up, potentially in the ground or something like that. But here's the thing. A physician is going to get bullied, right? And I hate to say this, but physicians get bullied by their patients because we have not properly trained our patients to understand that there is no prescription that could be written for a virus. People are like, well, they're writing prescriptions for ivermectin. Well, ivermectin was not necessarily created to treat COVID. They just happened to find that in a sample of studies, if you got it prior to it turning into a full-bore case of COVID, that as a parasitic disease, it could potentially help to eliminate that.
It's interesting. Why not that I want to get off topic onto ivermectin, but I just got an article the other day from JAMA, Journal of the American Medical Association. Last year, the Medicare program paid $130 million for ivermectin prescriptions.
I saw that.
So, it's interesting. So, we've got, when you're talking about these antivirals, Tamiflu is going over the counter.
Yep.
And there are now 2 drugs, right? We've got the Pfizer drug and we've got the Merck drug.
That's right.
One has only got a 30% efficacy. The other one's got a higher efficacy, but
about 52%.
Yeah. So both of those. So the original talk when I heard about it, I think there was some talk about making it a pharmacist dispensed medication, because if you think about it, if you go and get, whether it be a rapid or a PCR, you go and you turn up with a positive test, you've got COVID. The only way to get one of those medications is now I need to go to a doctor. And I know we've talked about this. I've blogged about it. I've talked about it. The impetus is now a doctor is going to say, I am not writing you a prescription until I see you.
There's the point right there.
I have shown up to you with a positive COVID test, what do we have to talk about?
Yep.
Right. So why couldn't a pharmacist do the drug? Now there are some drug interactions.
But
with
let's
both
be
of
clear,
these.
you're talking about a Pharm D.
Correct. But what I'm saying is, I come up with a positive COVID test. I need to get a prescription. The closest doctor I can get into, because you have to get it in a timely manner, the closest place that I can go to and get it in a timely manner is urgent care. Urgent care is likely not the doctor that I've been treated by or seen, maybe ever. If I don't sit and give this doctor every chapter and verse about my medical history, how is that any different? I actually think I have a better shot of getting the prescription more appropriately from a Pharm D who's going to say, okay, before I give you this, what medicines are you taking? What's this? Because you're typically going to wind up going to a pharmacy that you normally go to.
Right.
So that drug utilization review, but more importantly, the drug utilization review is coming from your prior pharmacy claims history.
Sure.
So the pharmacy the PBM has the ability to say, whoa, let's take a T. This drug has an interaction with this drug, and he's on that drug. The primary care doctor, urgent care doctor may not know that because it may not be your actual doctor you go to. So is there some strength behind an argument that these drugs should be dispensed at the Pharm D level?
Possibly, but the pharmacists aren't going to take this on. They're not going to want
because of the liability.
Absolutely.
I agree.
They didn't want to give vaccinations.
No.
Pharmacists did not want to give vaccinations.
You're 100% correct. If you go back and you take a look, when they first started moving it to the big box stores, right, to the CVS's, to the Walgreens, to the Walmarts, pharmacists didn't want to administer pneumococcals or the shingles vaccine,
any of those
flu shot. So it's a huge liability. But LinkedIn user, whoever you are, you're spot on. The physician, and they have every right to want that evaluation and management service, because let's just say, here's a hypothetical, right? So when Joe and I came back from Montana after, the holiday vacation and into the new year, we both came back. We both had COVID for the second time. Well, mine progressed and I wound up having pneumonia. Actually, I'm lying. I had pneumonia prior to getting the COVID. And so, a lot of folks need to keep this in mind. Even though they think they have COVID, get to the doctor and get that chest x-ray to make sure that you don't have pneumonia, because pneumonia, that's the bigger problem of this thing right now. So be careful, be smart, get to the doctor. Don't self-medicate yourself. Don't use Dr. Google or Dr. Bing or something like that to treat yourself. Get to a board certified, licensed, credentialed physician who can evaluate you properly, who has proper diagnostic tools and can make that determination as to what the proper course of care is for you based on your presenting problems, based on your underlying underlying systemic diseases, and really what they believe is the trend in your local market. Now, Jordan, you got asked a really important question, and I think this is so important. He said, can you comment on the quantity? Giving someone 4 test kits is like giving a single drink of water to a dying man. I agree. You can go through all 4 tests in a week.
Well, and it's going to be like the pregnancy test. You do the first one and it says you're pregnant. You're like, it's probably wrong. So I'm going to do another one right away to see if it's right. And since this test is only like 54% accurate anyway, to your point, likely somebody goes through this to double check a false positive or a false negative. So they at least go through 2 in one sitting. So they're done. Right. They're done in the first 2 days. So to that point, that in my mind is what fuels the fraud fire. Is they're going to be on the outlook of the government's not going to get me more, but I bet I can go find some more, and better believe that people are going to be there to deliver.
Yeah, I agree with you. And Pam, you're spot on. The majority of EMRs run a prescription, an e-prescription history. Right. So even the urgent care is going to have drug interaction information. But I do tend to agree with Eric that, I would defer a lot of these drug interactions to the pharmacist. And I talk to my pharmacist about all of this stuff, right? I mean, it's so important, to make sure that you're having these conversations about potential interactions, even if you're taking something over the counter, especially if you're taking something that is not properly monitored, right?
Right.
You see some of these groups like USP certification. What does that mean?
Yeah.
I mean, I don't know.
Pam brings up a good point about the EMR systems, but that also presumes that you're going to an urgent care that's got that. But even if you can run an ERX history, what if I'm going to an urgent care that I don't normally go to, and I'm not using my insurance because I don't have my card? I mean, there's a lot of things where the stars have to really align to be able to get this to be, correct. And that's where, I think, going, is this at the PharmD level? Is this the appropriate thing? I don't know the answer to this. I just think that it's, I know in here in Florida, they're doing the monoclonal antibodies. Although they've been told, the state of Florida has been told to stop doing it because it doesn't work against Omicron. They're still doing it, but they've now actually opened up clinics that are doing the AstraZeneca monoclonal, which apparently does work. And then I just went online today and saw that they're actually now opening up locations to dispense, or they will be when we start to get it, to dispense the Merck pill and the Pfizer pill. Oh, by the way, the AstraZeneca is not a monoclonal antibody for people who are positive for COVID. It's in lieu of getting the vaccine.
That's right.
The AstraZeneca shot is supposed to be like, a monoclonal antibody version of it. They're saying, I mean, obviously.
And now there's a pill that's coming out. This whole thing's continuing to go. But, Pam, I will tell you my opinion. These tests should not be in the home. This is not like a home pregnancy test. This is not like one of these 23andMe where you swab your cheek. This is a test that if you have underlying systemic disease, you face a higher probability of hospitalization and or death. If you don't get that swab done correctly, and let's say it gets cross-contaminated or contaminated in some way, and it goes to the lab and it's inconclusive or whatever it is, no, my opinion, I don't think these tests should be in the home unless they're being administered by somebody like a Melissa Dupree, who's a registered nurse, who, has the ability to make sure that she understands the proper way to get that test into somebody's nose. Now, Melissa may be hearing me say that, and she may be saying, why would you drag me into this conversation? Because I looked and I saw you had RN after your name. So I thought you'd be a good target. So welcome to the show, Melissa. All right. So let's listen, we can continue to talk about the pandemic.
We got to move on, because honestly, I'm getting to a point where I'm doing like a,
I know. And it was kind of funny because I was dragging my behind earlier this morning, and I just drank a cup of Cafe Bustelo espresso.
Yes, like
and let me tell you,
oh boy,
I feel the juice is running through my veins. So
is that going to be our new sponsor?
Listen, if we could even get a sponsor who would like us, we had one, and they don't even respond to me anymore. I know, I see 9line, and I'm just joking. Our sponsor still likes us. At least they haven't told us they don't. So anyways, let's move on. Jordan, you've been talking a lot about some really interesting analytics. You put a lot of stuff out there about value-based care and really the transition as to where things are going. And I'd love for you to kind of give us some down and dirty on some of the things that you're analyzing with your incredible team over there at OncoSpark, and really kind of what we need to be aware of, because what you talk about with the value-based care is going to lead me right into our final discussion on our topic today about the updates for Stark and anti-kickback statutes.
Sure. Yeah, no, absolutely. And if you guys can hear me okay, Sean, give me a hand signal if my signal breaks. We have a huge storm coming through right now, so it's liable to kick some of this, the internet connection. But the data is the most important thing right now. People are in panic mode to look at this data. Just like we all said, we don't even know how to track things. Yesterday, I was on the phone call with a very large system that's trying to come up with a plan. The physicians are getting sick. They're dropping the physicians. Do they cover remotely via audio, video communication? How do they do this? EMRs can't do it. So they're building their own systems in rudimentary Excel documents. That's because they're scared of when they get audited. To Sean's point, what he's always said, and Eric, you've always said, is it's a lot better to have something and it have been across the board than to have nothing and have hoped for it. So right now, the data piece, what we're finding out is a lot of people are reaching out to independent data firms and independent data individuals because the EMR systems just aren't set up to keep up with how fast this stuff's changing. So, I would say if you have some of those internal people, definitely look to them to help you. If you don't have those people, this is something where myself, Sean, Eric, whoever, we have these people to help you really drill down to a granular level, whether it's looking at compliance, whether it's looking at, preventative auditing, whether it's looking at financial operations. I mean, the hospitals right now are in a quick downward spiral due to the staffing issue, right? So their budgets are completely blown, $200 to some levels of nurses right now in certain areas because they can't get staff. That's not a sustainable model. They don't have the revenue from the other service lines because surgeries are still down because they can't get staff inside the surgical suites. So it's a very tough place, normal data situations. So being able to find that data and look at that data has been key to make that relational.
Yeah, absolutely. Great points, man.
Yeah. I got to see Jordan sent me some samples of some stuff because we're working on a couple of projects to develop together. And he sent me some samples of some of the analytics that were recently run by his guys. And it's not so much the analytics anymore because, everybody has a better mousetrap, right? I mean, there's only so many ways you can look at a CPT code. But really what is becoming the cool thing, and Jordan's guys have been doing an amazing job, it's the visualizations, right? It's that Power BI and how it looks and that, how does it visually look? When I was an agent, we would hate to look at spreadsheets and columns and spreadsheets and, but when you visualize it, it makes it very palatable to people who really need to see like, where is my data trending and stuff like that. So that's really where that value comes in. It's not the massaging of the data. It's how you're able to impart the information from that data.
Yeah, that's a great point. I agree 100%. All right. So are we ready to move into our discussion about Stark and anti-kickback statutes?
Let's do it, man.
All right. This is where I get to bore everybody to pieces.
Or enthrall.
You're all enthralled.
I mean, if you're a Stark and anti-kickback guy.
That's right. If you're a healthcare, regulatory person, or if you're a practice administrator, these are critical things that you need to be aware of. So let me start first with the significant changes that went into effect in January of 2021, because I want to make sure people aren't losing sight that things already went into place before we start talking about those going into effect in 2022. So effective January of 2021, there were 3 new exceptions for arrangements that facilitate value-based healthcare delivery and payment. Jordan, I know you guys are all over the value-based care, right? So they're looking at full financial risk. They're looking at value-based arrangements with meaningful downside financial risk to the physician, and they're looking at value-based arrangements themselves. Now, there was an extension of the value-based exceptions to indirect compensation arrangements that included a value-based arrangement to which the physician or physician organizations were a direct party. Okay. And then they added a new exception for donations of cybersecurity technology that includes hardware in addition to software and services. And then a new exception for limited remuneration to physicians capped at $5,000 per physician per year. And then a new definition, and this is really, really important. They added a new definition of commercial reasonableness. Okay. And we talk about commercial reasonableness all the time, right, Eric, when we're talking about, fraud cases and things of that nature.
Absolutely. Is the value of the benefit, what's the value? Yeah, that reasonable,
Right.
that commercially reasonableness is in rental agreements.
Right.
It's in services agreements. It's everything.
The question is, why would you pay a higher rate than what was commercially reasonable, right? That's the big question that I always get asked as a testifying expert. And excuse me, I apologize. So the new definition that went into effect in January of 2021 was that the particular arrangements, the particular arrangement furthers a legitimate business purpose of the parties to the arrangement and is sensible. That's a key word, that it is sensible, considering the characteristics of the parties, including their size, type, scope, and specialty. And the new definition also explicitly states, and keep this in mind, that an arrangement may be commercially reasonable even if it does not result in profit for one or more of the parties. Such an important revision or important addition to that definition. There were new definitions added for fair market value and for general market value. There was a codification of the concept that a single instance of forgiveness of an amount owed in a settlement of a bona fide dispute can be an isolated financial transaction. And then what they did was they created an alignment of the definition of physician with the meaning set forth in Section 1861R of the Social Security Act, which has the effect of limiting when doctors of podiatric medicine, doctors of optometry, and chiropractors are considered physicians for the purposes of Stark law. Really important, and especially in the podiatry community, you guys are getting targeted all the time, almost as much as the chiropractors are. So there were several more revisions that took place and other clarifications that took place. If you want, I'll post something to when I post the podcast about what these changes were in 2021. There's three things that I'd like to talk about with Stark before I jump to the anti-kickback. And Jordan, Eric, feel free to jump in at any point.
Well, I want to ask you a question, Sean. We're talking about commercially reasonable and what is sensible. I think that's an important part because if you look at, for example, in government contracting, and we've done a number of things in government contracting space, and I've been lucky enough to know this, is that when you're assigning a resource on an RFP, a request for proposal, and you come up with what that salary is going to be, it's off of a schedule that ties back to the Bureau of Labor Statistics and percentages, 50%, 60, 80, 90%, and all of that. And so, it's interesting to me that, for example, the sensibility issue, you've been doing this almost 30 years. You know the work as well as anybody. I know I say to you all the time, not to toot your horn, but there's a lot of truth to it that you have been a great agent because you understand the work. But from a compliance perspective, for someone who's been in the space for almost 30 years, what is commercially reasonable for someone to come in and be an external compliance officer may not be the same as what you should command because of your 30 years of experience in this. And so that adding in that piece of sensibility makes a lot of sense. Yes. But so I think from a services arrangement, that's probably the one piece I think that they were probably trying to target the most. But what other areas can you think of where obviously there's rental and things like that, but where does sensibility come in outside of the human element of experience?
Well, I don't think that it does. And I think that's a fantastic point, right? Because, you start to think about a lot of these diagnostic tests and the real implication to the Stark is on the technical aspect of these things, right? It's not on the professional side, it's on the technical side and the ability to share in those revenues. And Stark does a lot. I think this is the first time since 1989 that we've seen any kind of sensible update to the Stark law, right? I mean, we had Stark 1, Stark 2, Stark 3, there was a proposal for Stark 4, but none of, it's like what the late Senator Peter Stark said, and a lot of people really despise him, right? Because they think that this was all his concoction. But what a lot of people don't realize is that, the late Senator Stark actually came out and said, had I realized what this thing was going to morph into, I never would have pushed this legislation forward. I would have tried to find, and he actually used the term sensible legislation that actually fit based on where we were, rather than trying to figure out where we were going. I don't think you can look at commercially reasonable situations outside of tangible assets, right? Like, what you're paying for rent, what you're paying per square foot if you're building or purchasing something, or you're buying a purchase diagnostic test or something of those lines, right? I think it all comes down to, and that's why they went with the sensibility aspect of that, is to be able to say, look, if I do an SSEP or dermatomes upper and lower NCV testing on a patient, and I send this to a neurologist, as opposed to having a family practitioner review this, and no offense is meant, but a neurologist deals with nerve interference. And I think a neurologist is going to be the person, what a neurologist would charge for reviewing of that service test versus what a primary care would charge. I think you have to look at the difference in their scope of education, their knowledge base. And it comes down to, a sensibility situation where you say, yeah, I could get it done by a family practitioner who may look at one or two of these, a month, versus, paying $100 per test to a neurologist who does it, 1 to 2 times an hour. You know what I mean? So I don't know that you really can take that human element out of it when you're talking about the diagnostic aspect. I don't know if any of the attorneys out there would disagree with that, but after 30 years, I would like to think, that would be a sensible answer. Now, for 2022, there's 3 things that I want to talk about. First is when determining, and these are the changes that went into effect on January 1st of 2022. The first is that when determining whether the physician's compensation, meaning the share of overall profits or productivity bonus, is based on or is directly or indirectly related to or takes into account the volume or value of the physician's referral to the group or the practice, CMS actually stated that the new special rule for determining whether a compensation to a physician takes into account the volume or value of referrals and whether or not it applies. I think that's significant. Second is the fact that CMS finalized, with some modifications, its policy that profits from designated health services. Now, folks, you have got to check your DHS lists. One of the partners in my firm today, he's going to be dealing with a case. So I'm not going to say who his name is, because I don't need to run into a situation where they're like, oh, you were talking about our case. No, you don't know who I'm talking about. But he has a situation where a physician needed to know whether or not he could share or have others share in the profit distributions of the technical aspect of a certain type of cardiovascular test. When you go back and you take a look at each year of the designated health services list, CMS creates it by year, and they put them into spreadsheets, and then they do addendum throughout the year as to whether they're going to add to that list or they're going to take DHS services away. From 2000 and I'm just going to make up some years so that I can't tie it to the case. From 2016 through 2019, the services never appear on the designated health services list. Then in 2020, the services appeared on the list. And then in 2021 and 2022, the services are no longer on the list. So what does that mean? Out of 6 years, potentially, of DHS services, only 1 year would have an impact. And would that be enough to say that the physician was in violation of the Stark law? Potentially, because you should have known whether or not those services were on the list, right? Because that's what the government says. You should have known. It was your responsibility to know. So keep that in mind. Now,
that's an odd one, but that's an odd one though, Sean, right? Like something going on and then off and then back on. Like you should have known that's not
true. No, Eric, think about this. DHS services can actually change every single year. For 1 year, you may find a DHS that's on the list, and the next year it may not be off.
Sure, but
on the list.
It doesn't mean it. I'm just saying it's odd. Like, the fact that it happens, I get that it happens, but it's like, if you've got something that's not on the DHS list and then you look and it is, you're like, all right, we're not doing this anymore. And then all of a sudden it's like, ooh, let's go, bring the money
There's usually
vault in.
consistency on it. I think
Right.
a lot of it comes down to data mining, and they look at utilization of these services and they go, maybe there's a reason why we want to take a look at this. Let's go ahead and put it onto the target list and let's see if it violates the law based on the volume of these, these services. It's interesting. Seema Verma is supposed to be coming on my podcast with me on the compliance guy. And I may see if she wants to come on here with Jordan and you, and we can kind of talk about some of these services with Seema. But she's
gonna have to put on a hat, drink some coffee, and take a little bit of a verbal beatdown. If she can meet those criteria.
You just ruined your chances of getting her on this podcast. Okay, let me, for time purposes.
I just want to finish up the conversation we had at the last meeting. Yeah. But, to your point, I know we've got depressing time here, but, you talk about the Stark and the anti-kickback. Yeah. I'm curious as to what's going to happen given the financial situation of institutions with the rapid acceleration of mergers and acquisitions, when the Biden administration has said they're going to pump the brakes on those and make everybody do a second check of whether or not the mergers and acquisitions actually add value and benefit. But I know a lot of people are looking to that as a lifeline right now.
Are you saying murders and acquisitions, or are you saying mergers and acquisitions?
Hey, murders in the South, it sounds like I got peanut butter in my mouth, guys. But mergers.
Oh, is that what's in your mouth? Peanut butter?
Okay. So the last of those three is the most notable and significant change to the group practice structure, and the final rule is a new definition of overall profits. Now, this is really important because a group that can be distributed to physicians in the group, this is where you start getting into your pods of 5. Now, what CMS noted is that the stakeholders have expressed confusion about the definition. So with respect to the 5 physicians, right, because that's what I was talking about, CMS clarified that if there are fewer than 5 physicians in a group, overall profits means the profits derived from all the DHS of the group. It's all of it. And CMS also clarified that the overall profits means the profits derived from all the DHS of any component of the group that consists of at least 5 physicians, which may include all physicians in the group, and the distribution of profits from designated health services on a service-by-service basis is prohibited. So be careful with that. And the final rule also removes Medicaid from the definition of overall profits. So keep that in mind. Medicaid is out of the definition of overall profits in 2022. This will take me into the few things of the anti-kickback statutes, and there's a lot of them, but I only want to cover a couple of them. The most important one in my mind are the safe harbors resulting from the anti-kickback statute final rule. The first one, Jordan, is tied to value-based arrangements, right? So what the government did was they created 3 new safe harbors for certain remunerations exchanged between or among eligible participants in a value-based arrangement that actually allows you to foster better coordinated and managed patient care. I don't know how you can transition from volume-based care to value-based care without still having volume tied into it. It just doesn't make sense to me.
No, it doesn't. And I think that's, we go back to the data. You've really got to look at that as, right. You're talking about a 40-year window and you're just going to flip it on a dime the way it's been done for 40 years. And you're just going to say value. Well, who's defining the metrics of value? Who's setting the dollar based on those metrics? And then how do you elicit that buy-in? And the thought is, well, we're going to incentivize you and penalize you. And we've seen disaster in both of those approaches over the past 2 years.
I agree. And to your point, there's 3 aspects that they want to talk about here. Care coordination arrangements to improve quality, health outcomes, and efficiency, value-based arrangements with substantial downside financial risk, and value-based arrangements with full financial risk. And then shifting to the safe harbors, they do vary by the type of remuneration protected, meaning whether it's in kind or in kind and monetary. So what they're looking at are the levels of financial risk that are basically assumed by the patient and safeguards that are created to include these in their safe harbors. And the subheadings of these, without going into it because of the time, and I'll publish these: the patient engagement and support, the CMS sponsored models, cybersecurity technology and services, electronic health record items and services, outcomes based payments. Jordan, and I know you guys are doing a ton of this. Warranties, local transportation, and accountable care organizations. So ACOs are still very much in the mix of these things. And then the last one is with respect to the civil monetary penalties that prohibits inducements to beneficiaries. The final rule made a change to telehealth. And Eric, we probably want to talk about this in our upcoming presentation. Telehealth for in-home dialysis, and the amendment to the definition of remuneration in the civil monetary penalties rule is interpreting and incorporating a new statutory exception to the prohibition on beneficiary inducements for telehealth technologies furnished to certain in-home dialysis patients. And there's a great chart that was produced by the Office of Inspector General on this.
Yeah, so, they're probably talking about things like iPads and iPhones and some technology, because that technology is already being deployed in the chronic care management space.
That's right.
They're already doing that. So this is probably just to align to say, hey, it's not an inducement to someone who's on home, they're homebound on home dialysis, you know, and the technology of an iPad allows them the ability to get where they need to be with that.
That's right. Absolutely.
It's consistent.
All right. So that brings us to the end of episode 16, the first episode of 2022. Eric, Jordan, any parting shots, either at each other or just parting shots in general?
No, I just say wait a few days. The rules are gonna change, and wait a few days, and we'll see how long it takes this train to derail.
That's right. And Eric is silent. That doesn't happen often. All right. So listen, to all of the folks who joined in on the 6 different streaming platforms, I want to thank you each and every single one of you for joining in, logging on, tuning in, and just hanging out with the 3 of us on Coffee Compliance and Chuckleheads, episode 16, fraud of dreams. And we will be back next week, same day, same time, with a whole brand new episode. So stay tuned. Thank you again. Take care of yourselves, but more importantly, be good to each other.